Okay. Well, thanks to everyone for coming back. We're nearing the end of this 2-day marathon. My name is Mag Carbia. I'm an assistant professor in the School of Public Health here at the University of Minnesota, and I will be chairing today's session on health exposures and outcomes. Our speakers today, we're going to start with Todd Gardner. Todd is a researcher in the Center for Economic Studies at the U.S. Census Bureau. He notes that Steve Ruggles was his advisor when he received his PhD in history here at the University of Minnesota in 1998. He also teaches population geography at George Washington University. Next, we'll have Dr. Leah Richmond-Rakerd. Dr. Richmond-Rakerd is an assistant professor of psychology at the University of Michigan. Her research centers the development of problems in self-regulation, such as antisocial behavior, substance misuse, and self-harm, as well as the implications of self-regulation difficulties for processes of aging and inequalities in population health. Dr. Richmond-Rakerd frequently uses linked population data in her work, including administrative registries from New Zealand, Denmark, and Norway. So thank you to all of our presenters.
Okay, I'm Todd Gardner. I'm at the Center for Economic Studies at the U.S. Census Bureau. And any opinions I express here today are my own and do not necessarily represent the Census Bureau. I'm going to be talking today about micropolitan areas, and just to get the definitional issues out of the way, metropolitan areas are an urban core with a population of at least 50,000 people and the counties associated with it by commuting. Micropolitan areas are basically the same thing. They're an urban core and the associated counties, but the urban core is smaller, between 10,000 and 50,000 people. This area type was introduced with the 2000 census, and so now metropolitan areas and micropolitan areas both go under the umbrella term core-based statistical areas, or CBSAs. So I was able to gather data to apply the current CBSA rules to historical census years back to 1940. And micropolitan areas would have been a useful unit of analysis had they existed in the 20th century, because they accounted for a greater share of the population the further back in time you go. And in 1940, micropolitan areas accounted for 18.3% of the population, and that number is less than 8% now. Micropolitan areas peaked in number in 1960 and peaked in terms of population in 1980 and have been in decline ever since. So I wanted to look at what happened to areas that were micropolitan statistical areas in the middle of the 20th century. And so I identified 641 areas that qualified as the method criteria for being a micropolitan area in either 1940, 1950, or 1960. And looked at the long-range population trajectories of these areas. Initially, I was looking at 3 categories: those where the urban core grew and the population exceeded the 50,000 threshold, and they were reclassified as metropolitan areas. Other areas were nearby, in close proximity to a larger urban area, and as that larger urban area suburbanized, the micropolitan area was absorbed as an outlying county in the larger metro. And then there were a lot of areas that just remained micropolitan. So I looked at their population change from 1940 to 2020 and looked at what year did the population of that urban core peak, and how much has the population decline been since then. So I ended up with 5 categories overall. The areas that remained micropolitan but are still growing, not enough to be reclassified as metro, but we're still growing by 2020. And then there were areas that were in decline. And I split up the bottom 2 categories between areas that were in major decline, which I defined as losing more than 50% of their peak population, or dropping below the 10,000 population threshold, so they're no longer classified as micropolitan, and those that had just had moderate population losses. And this is a map showing the distribution of mid-century micropolitan areas with their long-range population trajectory. The dark blue are areas that were reclassified as metropolitan. The medium blue were areas that were absorbed into larger metropolitan areas. The light blue are the micropolitan areas with moderate population growth. And then the red are the areas the micropolitan areas that have gone into decline, with the darker red being the major decline areas. What's interesting to note is that of the 641 areas I was looking at, about half have been micropolitan areas that have experienced population declines. And looking now at all CBSAs that had core population declines, both metropolitan and micropolitan, you can see that the metropolitan, the bluish ones are the metropolitan areas that have experienced core population declines. Those are largely in the Rust Belt, can be explained mostly by deindustrialization. But it's a little bit more complicated when looking at micropolitan areas that have gone in decline. I think you have to, deindustrialization explains some of the declines in some of these areas, but you have to look at changes in the transportation network, the decline of passenger rail, also the structural changes in the agricultural economy to explain the population losses, because micropolitan areas that have experienced losses are distributed widely throughout the country. I'm looking now at some of the characteristics of these areas, and I'm using the same color scheme. The micropolitan areas that have gone into decline are the reddish shades here. And these figures show median age by area type for males and females. And the takeaway here is that micropolitan areas with declining cores are aging faster than the general population. And these show the racial and ethnic distribution of micropolitan areas. And again, the reddish shades are the ones I want to focus on here. Micropolitan areas that have gone into decline are disproportionately non-Hispanic white, and the non-Hispanic Black population and the Hispanic population have long been underrepresented in these micropolitan areas, particularly those with core populations declines. And so micropolitan areas are diversifying much slower than the general population. In terms of educational attainment, there's lower educational attainment in micropolitan areas generally, with women outpacing men. And this is especially the case in micropolitan areas that have experienced core population declines. In terms of health outcomes, there's a higher prevalence of diabetes and obesity in micropolitan areas, particularly those with declining cores. And these figures show all-cause cancer mortality. And micropolitan areas, particularly those with declining cores, have higher all-cause cancer mortality. And you can see how this is diverging over time. The figures were more clustered in 1980, the earliest data I have for data for cancer mortality, and have since diverged. And the final year I have is 2014 on this figure. Some of these poor health outcomes can be explained by lifestyle factors and the built environment. There's a much higher percentage of people in micropolitan areas that report having no physical activity. Smoking rates are higher in micropolitan areas. Binge drinking rates are higher for men in these areas. And I think this is the key figure here, and that is that life expectancy in micropolitan areas is lagging behind the general population. I have life expectancy here from 1980 to 2019. And again, you see this, how values were much more clustered in 1980, and there's been this divergence over time. All right, so there's been a lot of, in the literature review, there's a lot of talk about a rural mortality penalty. That is that studies show non-metropolitan counties have a mortality disadvantage. And a lot of these studies focus on the county level. And the reason for that is that a lot of health data is tabulated at the county level. The global burden of disease, the county health rankings and roadmaps, and the CDC all publish health data at the county level. So most of the studies that have focused on this have used established county typologies. I mean, the USDA's Economic Research Service has developed the rural-urban continuum codes, the rural-urban commuting areas, the urban influence codes. The National Center for Health Statistics has its own urban-rural classification scheme for counties. And I only found one article that was really focused on depopulation. The USDA's Economic Research Service even produced their own report last year. And I think it's kind of ironic that they didn't even use one of the 3 USDA ERS county classifications. They used the NCHS county classification. And even then, they collapsed it into metropolitan and non-metropolitan counties. And I put the one figure in the whole report where they actually isolated micropolitan areas. But what's problematic here, and this is more broadly in terms of the studies that have gone into this kind of associating that focus on the rural mortality penalty, is that in a lot of cases they use rural and non-metropolitan interchangeably. But the problem with that is that CBSAs, both metropolitan areas and micropolitan areas, contain both urban and rural territory. They're distinct concepts, and a lot of things get, a lot of variation gets overlooked if the terms are used interchangeably. So what I wanted to do was look at a finer geographic level, and I wanted to look at census tract data. And there are 2 databases I drew on for this, the HUD-10, which is the Historical Housing Unit and Urbanization Database, and the Longitudinal Tract Database, but they don't have health outcome data. But what they do have, the HUD-10 has a tract level urban-rural indicator, and the LTDB contains a number of tract level characteristics that, while they're not health outcomes, they get at sort of the well-being of the population. And what's interesting is that the urban tracts in declining micropolitan areas consistently have the least favorable values when you look at data from the LTDB from 1990 to 2017. Populations are aging faster, lower incomes, they have higher percent of the population with disability, higher percent of female households with children. And so what I did was I ran a regression, and with those variables as the independent variables and life expectancy as the dependent variable, and the R-squared value was fairly high. So I put these variables into a machine learning algorithm, a random forest machine learning algorithm, to predict life expectancy at the tract level, and then I reaggregated those to separate out the urban and rural populations for the area types that I've been talking about. And I put the urban parts of declining micropolitan areas in bold here to show that those are the areas that have the worst life expectancies. And again, these values are diverging over time, even worse than rural census tracts outside of any CBSA. So in conclusion, health outcomes vary substantially across micropolitan areas with different long-term population trajectories. Communities with sustained population losses have a number of, face a number of headwinds. And so these findings suggest that remoteness alone is not the primary driver of poor health outcomes, but rather it's the cumulative impact of decline that are at the heart of the health disparities in these when you look at these areas outside metropolitan areas. And I think that this means that we have to take population change into account when looking at things like the rural mortality penalty. Thanks very much.
All right, hi everyone. Today I'm going to share with you findings from 3 studies using nationwide register data from 2 countries that identify mental health conditions as a potential determinant of poor physical health in the population. Perhaps a bit ambitious to cover 3 studies in 13 minutes, but we'll see how I go. So this work has been carried out in collaboration with a number of individuals. This includes Barry Milne and Stephanie D'Souza at the University of Auckland, Terrie Moffitt, Avshalom Caspi, and Renate Houts at Duke, Gabrielle Davie at University of Otago, Fartein Torvik at Norwegian Institute of Public Health, Sidra Goldman-Mellor at UC Merced, and Lara Khalifeh, my doctoral student at the University of Michigan. This is just a disclaimer. Today I'll be sharing results from the New Zealand Integrated Data Infrastructure with you. These results have been created for research purposes and are not official statistics. So first, I'll just share with you why I think it's important to study mental health as a potential contributor to population physical health. I'll then share with you findings from studies, a set of studies in which we predicted risk for age-related disease and mortality, as well as physical injuries from mental health conditions. I'll then summarize the findings and key implications. So why study mental health? as it relates to physical health. It's been documented that across a number of industrialized nations, we've been observing a slowing or even a stall in gains in life expectancy since even before the COVID-19 pandemic. This is attributed to a number of causes. Among them are that in these countries, we are topping out on some medical interventions to extend life expectancy. So for instance, antihypertensive medications for cardiovascular disease, as well as in some nations, including the United States, a rise in causes of death from causes that are directly tied to poor mental health. So for instance, substance misuse and suicide. And so I think that this really necessitates a focus on the role of psychological contributors to health and life expectancy. In addition, mental health conditions are a modifiable risk factor. So effective prevention and treatment programs for mental health problems exist. And mental health conditions tend to onset in adolescence and young adulthood, early in the life course, whereas chronic physical diseases tend to onset later, and other kinds of physical health problems, for instance, physical injuries, occur over the lifespan. So this suggests that prevention and treatment of mental health conditions early on might have knock-on benefits for physical health later in life. All right, so now I'll share findings with you from two studies in which we predicted risk for age-related disease and premature death from mental health conditions. In these studies, we asked whether mental health conditions are associated with subsequent premature mortality, as well as subsequent age-related physical and neurodegenerative diseases. And we also evaluated diagnostic specificity, so the extent to which associations were present across different kinds of mental health conditions, different kinds of physical diseases. So these data came from the New Zealand Integrated Data Infrastructure, or IDI. This is the collection of whole-of-population administrative data sources that have been de-identified, linked at the individual level, and made available for research. So to measure mental health conditions, we used public inpatient hospital records, so using ICD codes. Here, so mental health conditions were operationalized as disorders in the ICD. We measured all 9 categories of mental health conditions shown here. And because we had temporal information about date of diagnosis, we could follow people forward from their index condition, so that first mental health admission during the period. We measured chronic physical diseases also using public inpatient hospital records. We measured the 8 chronic conditions shown here. And we measured dementias using a published ascertainment scheme by Catherine Walsby and colleagues that utilizes public inpatient hospital, mortality, and pharmaceutical records. We measured the full range of dementias. So these include Alzheimer's disease, as well as other dementias, such as frontotemporal and vascular conditions, for instance. So in our first study predicting mortality and physical disease, our study population was aged 10 to 60 at baseline. We followed them for 3 decades, so they were aged up to 90 years at the end of observation, and we had an N of 2.3 million. So first, we found that mental health conditions are associated, as we would expect, based on prior research, with premature mortality. So this figure shows the cumulative probability of death across time in years. This is shown for individuals with a physical disease only in blue, a mental health condition only in orange, both in purple and neither in yellow. Zeroing in on this orange line, what we see is that individuals with a mental health condition died younger, on average, than those with neither a mental health condition nor a physical disease. So mental health conditions predict premature mortality. What about morbidity? This figure shows the relative risk of a subsequent physical disease among individuals with any mental health condition, as well as different kinds of mental health condition. Importantly here, we adjusted these models for pre-existing physical diseases to address the potential for reverse causation. So the potential for poor physical health to lead to poor mental health rather than vice versa. What you can see here is that all of the mental health conditions that we studied were associated with elevated risk of subsequent chronic physical disease. So I've shown you that mental health condition, all the range of mental health conditions that we studied were all associated with elevated risk of subsequent physical disease. We also observed elevated risk for the range of physical diseases that we study. So this figure shows the percentage of individuals with a mental health condition in purple. Oh, excuse me. With a mental health condition in purple and without in blue, having received a diagnosis of these 8 physical health conditions, and you can see that those individuals with a mental health condition had elevated risk of all. Now, you might rightfully say, well, these are inpatient hospital records. These will tend to capture a more severe disorder and disease, and these will also capture a much smaller subset of the affected population. Absolutely right. So we were really pleased to see our findings replicated recently in nationwide primary care records from Norway. These records capture a much broader range of severity and also a broader range of the affected population. And I'll share with you more about these records in a few minutes. So I've shown you that mental health conditions predict chronic physical diseases of aging. What about neurodegenerative diseases, so it's dementia specifically? So we carried out a follow-up study in which we predicted risk for dementia from mental health conditions, again in the IDI. Here, our study population was aged 21 to 60 at baseline. Again, we observed them for 30 years, and we had an N of 1.7 million. So this figure shows the relative risk of any subsequent dementia among individuals with different kinds of mental health conditions. Importantly, here we excluded individuals with evidence of pre-existing dementia, and we also adjusted for the presence of pre-existing chronic physical diseases, the 8 that I showed you earlier. What you can see here is that all mental health conditions were associated with subsequent increased risk for subsequent dementia, particularly marked for instance, psychotic and substance use disorders. So you might see where I'm going here. The full range of mental health conditions were associated with elevated risk of subsequent dementia. We also observed associations across different dementias, including Alzheimer's disease, as well as all others. So I've shown you that mental health conditions predict risk for chronic physical and neurodegenerative diseases of aging, as well as premature mortality. What about other kinds of physical health conditions? In more recent work that we've been carrying out that's approaching publication, we've addressed this question. So now using nationwide registry data from 2 countries, we have asked whether mental health conditions are associated with subsequent physical injuries, and specifically unintentional injuries in addition to self-harm and assault injuries. So risk of injury for self-harm and also from victimization is well established as a function of poor mental health, but unintentional injuries have received comparatively less attention despite comprising the bulk of population injuries. So that was really of interest in this study. And then again, we evaluated diagnostic specificity, so the extent to which associations were present across different kinds of mental health conditions and injuries to different body systems and regions. So here our 2 study populations were drawn, first from the Norwegian Nationwide Primary Care Register that I referenced earlier, as well as again the New Zealand IDI. Our populations were 10 to 60 years old at baseline. In Norway, we could follow them for up to 14 years, in New Zealand for up to 30. The ends are shown here. So as I mentioned, in Norway, we measured mental health conditions and injuries in primary care records. So this is done using the International Classification of Primary Care, or ICPC-2. Here, conditions are coded across different chapters. So the mental health chapter includes a range of symptoms and diagnoses of mental health conditions, and then injuries are coded across a range of different body systems. So that was useful for our purposes here. I'm sorry, this slide should have a reference. This nice schematic came from a paper led by Avshalom Caspi in Nature Mental Health just last year. So in Norway, we measured these conditions in primary care records. In New Zealand, we measured mental health conditions using inpatient hospital records, as I showed you previously, and injuries as well. And then we also utilized a unique New Zealand database of injury insurance claims. This is maintained by the Accident Compensation Corporation, or ACC. The ACC is the national provider of no-fault personal injury coverage to New Zealanders. All New Zealanders are eligible for coverage regardless of how the injury occurred or where it was treated. And so this database captures injuries of a much broader range of severity than inpatient hospital records do. So first, we found in the Norwegian primary care records that mental health conditions were associated with a risk of elevated risk of subsequent injury. I know the font's a bit smaller here, but what this is showing is the hazard ratio for risk of subsequent injury as a function of any mental health condition on top and various conditions going down, for instance, ADHD, anxiety, psychosis, and PTSD. Risk of injury is shown for injuries across different body systems. Those are shown in different colors. What you see here is that with the exception of injuries to the eyes and ears, all mental health conditions that we considered were associated with elevated risk of injury to all body systems. Risk of injury was particularly marked for injuries in the neurological system. Those are shown in light gray. I'll return to that in a few minutes. Importantly here again, we adjusted for pre-existing injuries that predated people's mental health encounters and for mental health conditions in primary care to address the potential for reverse causation. So mental health conditions were associated with elevated risk of injury in primary care records. They were also associated in inpatient hospital records. So here you see the adjusted relative risk of any subsequent injuries among individuals with a mental health condition. As you would expect, individuals who've had an inpatient hospital admission for a mental health condition have markedly elevated risk of subsequent admission for self-harm injury. as well as assault injury, but perhaps less expected, they also have elevated risk of admission for unintentional injury. All of these associations also shown here control for pre-existing injury. And as you see at the bottom, individuals with a mental health admission also were more likely to they accumulated more injuries in injury insurance claims. So I showed you in the primary care data that mental health conditions were associated with risk of injury to different body systems. In the inpatient hospital data, we found they were also associated with risk of injury to different body regions. So this is a heat map showing the relative risk of injury to different body regions, And what you can see here is that individuals with a mental health hospital admission had elevated risk of injury to different body regions, but risk was particularly elevated for injuries to the head, face, and neck, including TBI. You might recall that this aligns with what we saw in the primary care data in terms of increased risk of injury in the neurological system. All right, so now I'll just summarize what I've shown you and what I see as kind of the key implications. So I've shown you using nationwide registry data from 2 countries that people with mental health conditions develop excess age-related physical and neurodegenerative diseases, and they die prematurely. In addition, they have increased risk for health problems that extend beyond chronic diseases of aging, including unintentional injuries. Associations are transdiagnostic, so they're not specific to just one type of mental health condition, one type of physical disease, or injuries to just one body system or region. And associations remain after addressing reverse causation and other alternative explanations. So I didn't have time to show you this here, but we've also shown that these associations are robust to control for other potential key confounders, so including indicators of socioeconomic background. So I think these findings have a number of important implications, but the key one is that if associations are causal, ameliorating mental health conditions in young people might help to reduce the burden of age-related diseases and other physical health problems in older people. But even if the associations I've shown you are not causal, our findings identify mental health conditions as a key indicator of risk for poor physical health over the lifespan. So before I close, I just want to alert you to a couple of papers by my colleagues and myself focusing on the use of population administrative data in developmental and social science research. Here we outline prior scientific advances as well as a future research agenda. And I think building on the really kind of excellent talks that we saw this morning and more general conversations I've had throughout this meeting, the methodological and ethical considerations in use of population administrative data. So I'm happy to share these papers with anyone who's interested or the other reports that I've shared with you today. I'll close by acknowledging the funders that have supported this work. Again, my many excellent collaborators. You can find me here, and thank you for your attention, and I'll look forward to your questions in the Q&A. Thanks.